Okay, good morning, everybody. Nice, cold, chilly morning, wake you up. So we're very pleased this morning in our sort of schedule of special grand rounds to have Dr. Van Yu with us. And Dr. Van Yu is the Chief Medical Officer of Janian Medical Care, which is an affiliate of the Center for Urban Community Services. We were just trying to remember what projects we've done with them before. He previously served as director of Janian's Medical Care's project for psychiatric outreach to the homeless. I think that has something to do with PPOH that's on the screen. Psychiatric outreach to the homeless. I don't know where project, got it. Which provides psychiatric care at 54 community programs serving homeless and formerly homeless New Yorkers who might otherwise not access care. Before joining whatever that is, POO, in 2003, Dr. Yu was an attending psychiatrist and then associate director of Bellevue's Center for Comprehensive Psychiatry Emergency Program. He's a New York educated physician, earned his medical degree from Stony Brook, and completed his residency at NYU. He currently is clinical assistant professor at the State University of New York Downstate and at New York University. From 2011 to 2012, he served as president of the New York regional branch of the American Association of Psychiatric Administrators and the American Association of Community Psychiatry. In 2003, he participated as a work group member in formulating New York City's Department of Health and Mental Hygiene's recommendations for improving the transition from police custody to hospital treatment. So I want to thank you for joining us this morning, and we've all been looking forward to this talk, so take it away.
Thanks, everyone, and hi, Beth Israel in Kingston. I can't see you anymore. I have about 50 slides here. We're obviously not going to get through them. I'm going to just talk until about 20 of or quarter of, and then see if you guys have any questions. And what I will do is get through all the photographs. So wherever I am, I'll stop and get through all the photographs. So I'm a psychiatrist. I'm not a family medicine person, so that's the first caveat. And when I first was talking to Dr. Kalman about this, we were talking about me trying to talk about family medicine for homeless people, but I decided that's not my expertise. We did start a small primary care operation in our agency a couple of years ago, and I actually encourage you to invite my person who's running that, Margot Simon, to come talk to you guys about that at some time in the future, so that's my plug for her. But what I'm going to do is I'm going to talk to you about psychiatry services for homeless people, and I'm hoping that gives you a sense of sort of the system in place in the city to serve homeless people in general. And also, I know you guys are working, or those of you who work with homeless people, are working with people who have serious mental illness and are probably in contact with the psychiatric system working with those people. So I think it's just helpful to know that. So I'm hoping that sort of leads to further collaborations about that kind of thing. So what is up with Winnie the Pooh? So when I started with the agency, I was running this project called Project for Psychiatric Outreach to the Homeless, which I'll tell you more about a little bit later. And that, if you can remember that, there's like all these initials. You guys are IFH, right? There's CUCS, there's PPOH, there's Janian. So I think the thing that people remember, if they're asked about this 2 weeks later, who is that? Where is he from? If you remember Project for Psychiatric Outreach to the Homeless, that really actually describes a lot of what I do. And that's PPOH, not POOH. So that's what this slide comes from. It's designed to wake people up at 8 in the morning. Okay, so let me just launch into this. So if I was going to be standing here for 4 hours, we would do all of this, but we're not going to do all of this. We're going to probably do the first 2, maybe 3 things here. So the first is to familiarize clinicians with strategies and tactics for practicing psychiatry with mentally ill homeless people, which is a very different kind of practice than what I was taught at residency. So hopefully we'll get into that a little bit. I'm going to start with the scope of the problem. How many homeless people are there? What kind of problem is homelessness? Some of the things being done to do something about that. and then some challenges and advantages of practicing in the field. So we, as the Project for Psychiatric Outreach to the Homeless, find ourselves practicing psychiatry on like church steps, for example. And how is that different than practicing in an office? Well, it's very different. And there are some challenges to that, as you can imagine, but there's actually also lots of advantages to doing that. So hopefully we'll get into that. And I guess it's a small enough crowd. Just stop if you have any questions, and I'll try to remember to repeat the question for the crowds in other places. Okay, I'm just going to put the whole thing up here. Okay, so why does an entity like the Project for Psychiatric Outreach to the Homeless exist? Well, here's the issue. So back in the mid to late 80s, people were asking, well, people have been asking this question for a long time, but in the mid to late 80s, a certain kind of answer started coming. And the question is, well, why are there so many homeless people? Like, what is the issue, right? Is it a housing issue? Is it an economic issue? Is it a political issue? Like, what's going on? For single adult homeless people, not families, families we'll talk about in a second, but for single adult homeless people, what was sort of realized in the mid to late 80s is that it's primarily a psychiatric problem, right? That it's psychiatric illness that leads to homelessness and then maintains people in homelessness. So if you want to do something to sort of fix homelessness or to reduce homelessness, you have to bring psychiatric services to bear on the problem, right? And I'll explain that a little bit more in an upcoming slide. So that's the first issue, that single adult homelessness is a psychiatric problem. Family homelessness, just to give you a little preview, is more of a socioeconomic problem, right? I don't meet a lot of homeless families because it's not my expertise, but when I meet homeless families, who I'm usually meeting is the head of household, which is usually a single mother, yes? And these people are not particularly mentally ill, okay? So they end up in homelessness for a lot of socioeconomic reasons. One of the most common ones being domestic violence. That's a lot of what I see because we work at a domestic violence shelter. So getting back to single adult homelessness, however, so something like, depending on what paper you read, more than half to 2/3 of single adult homeless people have some kind of serious mental illness. Like, that's the take-home message for the morning. That most people who are seriously mentally ill have some kind of serious mental illness. So that's like schizophrenia, schizoaffective disorder, the mood disorders, and post-traumatic stress disorder in all its forms, yes? And then something like 2/3 to 3/4 of single adult homeless people use drugs or alcohol. And when you see that, you certainly see the connection between drug and alcohol use and homelessness. Okay, so that's the first thing. The second factor in all of this is that homeless people do not use the community health system that has been created to serve them among other people, right? So the study I like to quote, I always forget the name of the person, but I think it was in LA, somewhere on the West Coast, asked this question. If you take all the seriously mentally ill homeless people, and in Los Angeles it's mostly people living on the street, I'll explain that in an upcoming slide, and ask, where do these people get their mental health care? Well, the answer is only 1 out of 5 of those people are getting any mental health care in the system, right? And 4 out of 5 people, and this study was done like 20 years ago, don't get any mental health care at all, right? And so, again, this was like sort of realized in the mid to late 80s. So with that realization, you decide, so if I'm gonna have psychiatric care for mentally ill homeless people, I've got to bring the care to wherever they are. They're not coming to me, right? And if you think about that for 3 seconds, you realize, there's all kinds of reasons if I'm a homeless person, I'm not going to a community health center, right? I am not really welcome in the waiting rooms. I'm stigmatized in the waiting rooms. I have a 15-minute appointment that I have to be at on time. I don't even know what time it is half the time, right? It doesn't, like, that kind of system doesn't really work well for homeless people, especially mentally ill homeless people. Does that all make sense? So that's why we exist, right? Okay. So then this is my one slide for you guys. So I just got through telling you that single adult homeless people are mentally ill and or use drugs and alcohol. Yes, for the most part, okay. But what's also true is that this is a population that has a high burden of medical problems, right? like a lot of chronic medical problems. The thing that I see most often, because I'm a psychiatrist, is metabolic syndrome. And a lot of that metabolic syndrome I cause. So I'm treating a lot of that. I'm not personally treating it, but I'm seeing a lot of it. And then there's like there's COPD, like that sort of thing, because there's like a lot of smoking. And then a lot of medical problems related to alcohol and drug use. For example, a lot of liver problems and pancreas problems, right? You can imagine. Okay, so the one statistic here's another statistic I want you to remember that has been talked about for the last couple of years is this thing on the bottom. So Americans with serious mental illness, I'm not even talking about homeless Americans with serious mental illness, just Americans with serious mental illness have a life expectancy as much as 25 years less, right, than people who are not seriously mentally ill. 25-year life expectancy gap. About 40% of that to a half of that is suicide, right? So if a 20-year-old commits suicide, that brings the whole average down. You get that, right? So and for serious mental illness, there's something between like a 10 to 15% lifetime risk of suicide, right? So that accounts for about half of this 25, but that still leaves you with about 12 years, right? And if you look at, I don't have slides to show this, but if you look at why are these people dying 12 years earlier than their non-mentally ill counterparts, you'll see it's a lot of chronic, preventable, and manageable medical illness, a lot of metabolic syndrome, cardiovascular disease, that sort of thing. Okay? Okay. So if you're going to help a seriously mentally ill American, you really have to have like 6 things in place for them, right? So if I'm the psychiatrist, like at the Bellevue Mental Hygiene Clinic where I did my residency, right? I was just thinking of one thing, right? Like, what's the right dose of risperidone, and is this person taking it, right? And the answer is the person's usually not taking it, right? So, like, I think a lot of what I did at the Bellevue Mental Hygiene Clinic when I was a resident for homeless people, I wasn't doing much, right? I was like prescribing medicine that nobody was taking, or I was prescribing medicine that was being sold on the street, right? There was a lot of that going on, right? And it never occurred to me to think, oh, like, what else could I be doing? Well, if I was going to really help a person like that, I've got to do these 6 things. And I'm not saying you personally would do all these 6 things, but you want to have a system in place to do all these six things. So that's income support. So that's things like public assistance, supplemental, so SSI, whatever that stands for, SSDI, things like that, right, which is disability insurance. Housing support, right? So that's like what my agency does. We provide a lot of so-called permanent supportive housing for formerly homeless people, right? Either mentally ill or not. So there's a whole, like I could do a whole other 2-hour talk just on the housing system for formerly homeless people. Medical care, psychiatric care, which is what I'm talking about today, substance use disorder treatment, right? And then these quality of life supports, things like supported employment and supported education. So supported employment and supported education are these 2 evidence-based practices that are utilized for seriously mentally ill people that, just what it sounds like, helps people get work and enroll in school and do other educational activities. And as evidence-based practices, they've been shown not only to get people working, for example, for supported employment, but it improves their sort of clinical outcomes. I know for psychiatry, now that I'm saying that, I don't know if anyone's looked at does supported employment helps people's medical outcomes. I bet it does, but I don't know that anyone's looked at that. So next time I give this talk, I'm going to know that. Okay, so now our first foray into photographs. If I don't say otherwise, it's a photograph I lifted from Google, right? None of these are mine. I should probably say where I got these from, but I have been lazy about that. This slide is to remind me that even in New York City, there's a lot of this kind of homelessness under bridges and in sort of like natural or wooded areas, right? I was just giving a talk at Columbia yesterday, and they're like close to Fort Tyrone Park, where there used to be lots of street homeless people living in the park. So if you're working on a street outreach team, which I used to, wear good boots. This is what we're more used to, right? Seeing in the streets, right? This is a slide to remind me, this is actually not a huge problem in the city, but 99% of shelters and supportive housing sites do not allow dogs. So this is a problem for some people because they're not giving up their dogs, so they refuse care and help, right? So we have a couple of supported housing sites, the Prince George and the Times Square, the old Prince George and Times Square hotels that allow pets. So I love going there because I'm always in the elevator with a dog, right? Going up and down the floors over there. So you actually want to know this. If one of your clients is homeless and has a dog, you want to know like what's going on with the dog, because that's going to be a big obstacle to care and placement. Here is a photograph from the subway. This is to remind me that there's a lot of homeless people hanging out underground, and if we have a chance, I'll tell you how those people are served differently. This is a photograph I took, okay? So this is a cart full of stuff. For quite a while, I was waiting on the subway platform. I couldn't find the person who was connected to this stuff. But I put this slide up to ask anyone, there's no way you would know this, but like, what subway platform is this? I'm gonna just tell you. This is not East New York. This is not the middle of the Bronx. This is West 4th Street, okay? So this is underneath one of the richest zip codes in the country, and this is going on, right? In fact, I think this is more common in the richer zip codes in the subways, right? Because I think it's like a little bit easier to be homeless with a big cart of stuff under West 4th Street than it is out in East New York. I think these people just don't get harassed as much in those kinds of places. But I haven't tested out that theory. But just to remind me that this is everywhere, even here in the, like one of the richest cities in the world. I used to work at the street outreach team that covers the financial district, which was like such a surreal experience. Like every day I'm out in the street, like working with people, like literally across the street from the stock exchange. So like that was always like the surreal experience for me. Okay, this is an ad that appeared in the subways like for a second years ago. It says, "Your generosity is killing me. Give spare change to agencies instead of panhandlers." So first thing this reminds me of to say is that most panhandlers are not homeless, right? Most panhandlers live somewhere, often in government runs, some kind of government run operation. But most panhandlers are not homeless. Secondly, no panhandler worth his salt spends a dime of the money he gets on food, because there's free food all the time in this town, right? Like every church basement and synagogue has free food at some point during the week for homeless people, right? So homeless people are not, and panhandlers are not spending their money on food. They're spending their money on drugs and alcohol. Now, I'm not advocating that you don't give money to people. I give money to homeless people. But just, you should just know where it's going, right? So for example, there used to be this guy, I work at this place on 24th Street, and I used to take the 1 train there. And there used to be this guy in that subway station who was like always smelling of alcohol and asking for money. And I kind of got to know this guy a little bit, and I would give him money frequently, even though I knew he was just, going above ground and buying Georgie, those little 375 vodka bottles. But I was doing it anyway, so. Okay, so here's some statistics. So I'll just read the first line, and then I'll just read the first line. So nationwide, so this is to start giving you an idea of how big a problem this is. On any given day in the United States, there are about 750,000 homeless people. So right now, there's 750,000 homeless people in the States, somewhere, right? And there are about 3 million episodes of homelessness per year. Okay, some of those episodes are very short. In fact, probably most of them are. And many, many people, if not most homeless people, have an episode and then they leave the episode of homelessness to be rehoused somewhere and sort of never come back into the system, right? Or become homeless again. So there's a lot, like a lot of things, there's many more episodes than there are actually current people. So that's sort of nationwide. So the next thing is some statistics of New York City. Okay, if you look at the Department of Homeless Services website, right, which is, so it's newyorkcity.gov/DHS, right? They actually publish their shelter census every day. So here's the 23rd of August in 2010, okay? I have a more recent one. So on that day, the shelter census was 35,000, okay? I'm gonna skip ahead. Here's December 9th, 2011. Now we're up to 40,000. So I'm just looking at the total shelter census. I'll do the other numbers in a later slide. Here's 23rd of May, 14. Now we're up to 53,000. See what I'm doing here? I'm giving you the trend. And here's the most recent one I have. So it's January 5th, just last month. Now we're up to 58,000. right? So where did we start? 35,000 in August of 2010 to 58,000 this last month. Okay, so the shelter population has been growing steadily for the last few years for the variety of reasons that's happening. I don't even understand all the reasons, honestly, but the economy, of course, being a huge part of this, right? So I want to point out some of the numbers underneath. So look at the single adult men, and remember this, these are just the shelter numbers. The hope count is the street number. I'll explain that in a minute. So single adult men, 8,000, single adult women, 3,000. That is a very, very consistent ratio. There's about 3 times as many men who are single adult homeless as there are single adult homeless women. That's like always, and the ratio is also the same in the streets, and no matter what city you look at in the States. I don't actually exactly understand why that is, but it's very consistent. And then look at the next, children. That's 25,000 children. That's a number that always drives me crazy, right? What was it in 2010? It was 14,000. Do you remember those ads in the Coalition for the Homeless would have these ads in the subway that would have a picture of a child and 14,000? Well, over the years, I've watched that number grow, right? So now it's 25,000. And those accompanying adults are mostly their mothers, right? I sort of mentioned that in passing earlier. Okay. So that's what the shelter population looks like. And then the shelter is divided basically into 2 big categories: family shelters, single adult shelters, right? And like I know the single adult shelters, the family shelters I don't know that much about, right? And then even the single adult shelter system is divided up again into specialty shelters, right? So we operate a couple of shelters for mentally ill people, right? And there's so-called working shelters. So there's like different kinds of single adult shelters. Okay, what's the HOPE count? HOPE stands for Homeless Outreach Population Estimate, right? So every year, I believe it's the 3rd Tuesday of January, overnight, these teams of volunteers go out and count homeless people. They divide the city up into like areas, and you count your area. So they get that number, and they do some kind of fancy statistical analysis or statistical maneuvering to it to get this number. So this 3357 is not the raw number. It's a statistically manipulated number. And that's how you get the HOPE count, right? So let's see what's been going on with that. So here it is, 2010. So it's been about the same, 3,000, 2,600, 3,100 again, and then 3,400, that's last year. This year's HOPE count was actually postponed because of the snowstorm. That wasn't really a snowstorm. And then I think it was done last week. So the 2015 HOPE number should be out sometime in the spring. And I always put that 2005 number, it's 4,395, to show that it's actually significantly less. The shelter census has, as you saw, increased a lot in the last 4 or 5 years. The street number has actually been pretty stable. It actually went down between 2005 and 2009 significantly, and then sort of has bumped up a little bit to about 3,000. Okay, just to give you a sense of numbers, like what does 58,000 mean? So the 2013 New York City Marathon had 50,000 participants. So imagine all those people streaming across the Verrazano Bridge. Like that's how many homeless people there are, and more, right? And then Yankee Stadium filled to the brim for a baseball game is 50,000 people. So add 8,000 more, and you've got the shelter count. That's not even putting in the street count. So that just gives you a sense of the scope of this, right? Despite that, here's homelessness in different cities. The ratio of homeless people in New York City is actually pretty low because there's so many people in New York City, right? Does that make sense? So it's only 1 per 2,700 people in New York City is homeless, which, look at LA, it's 1 in 150 people. It's like a big difference. Also, look at the street homeless number. In New York City, it's about 3,000. In Los Angeles, it's 25,000, right? So even though there are fewer homeless people in Los Angeles, they're mostly outside, mostly not in the shelter system there, okay? There's 2 main reasons for that. You're going to guess one of them, but you're not going to guess the second one. No one ever guesses the second one. Someone shout out one of the reasons. Weather, right, so weather. So warm places have more people outside. The second reason, does anyone know before I? The second reason is legal. New York State is the only state in the country where there's a so-called legal right to shelter. If I walk into a shelter today, New York City is obligated to find me a shelter bed. No other state in the country has such a law. This is case law. It's the Callahan case, if anyone's interested. So Los Angeles does not build a shelter system for its homeless people because it doesn't have to. There's no legal obligation to do so. Does that make sense? I mean, it doesn't make sense, but that's the reason, right? Okay. So why are there so many mentally ill homeless people? Deinstitutionalization is the number one reason, right? So if back in the heyday of the state hospital system, so seriously mentally ill people in this country, and certainly in New York State, were primarily treated by a state hospital system. This is back in the 50s and 60s, right, and before. So if we went back to 1955 right now and asked how many state hospital beds were filled with mentally ill people, it would be about 90,000 beds in 1955, right? And many of those 90,000 were people who were basically living in those beds. It was institutional care. Yes? Okay. Then starting in the 60s and 70s, two things start happening to empty the state hospital beds. The first thing is this whole like social movement to free people from the chains of oppression, right? Which was a lot triggered by stories of real problems at the state hospitals, like real horrible barbaric care that some of these people were getting. Like that was real, right? Not across the board, but certainly there were instances of this that was creating furor over this. But that's probably not even the main reason this happened, right? Who pays for the care of state hospital patients? New York State, right? Remember in 1960, whatever it was, Medicaid and Medicare happened, right? So who pays for your outpatient visit in a community mental health clinic? Washington does, Medicaid, right? So that was one of the big drivers in deinstitutionalization, get people out of the state system and get their care paid for by Medicaid. It shifts the cost to Washington, right? So in the midst of all that, there was this community mental health system like created to transfer care from inpatient state hospital system to outpatient, right? Now that community mental health system still exists, but it doesn't serve these people. I mean, they do really good work and they serve people, but not these people. Why is that? So if you're a state mental hospital patient and you get released in 1962, what's the first two things you do, right? The first thing you do is take your bottle of haloperidol and throw it in the garbage, right? Because you have anosognosia. Schizophrenics are unaware of their illness, right? Something over 50% of schizophrenics, if you ask them, do you have a mental illness? They'll say, no, I don't. So why do I need haloperidol? I don't. So in the garbage it goes. And the second thing you do is go to the bar, okay? And you start drinking or drugging or whatever. So now you have a population of untreated, seriously mentally ill people who are using drugs or alcohol. And those people are not really maintaining apartments so well, okay? So you have a population of people now who are too young to have ever like really lived in a state hospital, but this is the population that would have been state hospital patients, a lot of them, if the state hospital system still worked the way it did. There's something less than 10,000 active state hospital beds now. Does that make sense? Do you all get that? Okay. And the other two things leading to mentally ill homelessness is the shifting the American economy, which is this. Until 20 years ago or 30 years ago, you could make a very good living in this country being not well educated, right? There was all kinds of manufacturing work that was unionized, that had really good benefits, and you could like really live a solid middle-class life with poor education. That is like largely not the case anymore in this country, right? Certainly not the case in New York City. It's very, very difficult to make a living with poor education. The American economy is much more service-oriented than it once was, and a service-oriented economy requires more educated workers, yes? So you have a swath of people who were it 1955, would do really very well for themselves, who like are really disenfranchised from the economic system right now. This is like in the New York Times every single day, like this kind of thing. Add to that, if on top of that you're seriously mentally ill, like you are going to have a lot of trouble maintaining your home. Yes? And then the last thing is this decrease in low-income housing, which if you just like hang out in New York City for 5 minutes, you realize that that's going on, right? I'm getting priced out of my I moved to Brooklyn because I got priced out of my Manhattan neighborhood, and now I'm getting priced out of my Brooklyn neighborhood, right? And I'm a professional who makes a salary, right? Like, so imagine, you know, just take a second, you know, just read the New York Times every day and imagine like, oh, what must it be like to be making something like the minimum wage and trying to like have an apartment in New York City? Like, where are you gonna live? Like that's what's facing. And then on top of that, you're seriously mentally ill. Okay, does that make sense? Like why this is a phenomenon? Okay, and why it's getting worse? Let's skip this. Okay, I got 5 minutes. Let's go to some photographs and then I'll see, well, let's see. Here, let's do this. Let's do a couple more, then we'll do photographs.
Can you just
Yeah.
make sure you have time to tell us like what you do to treat folks
Yes, okay.
for a few minutes?
Yes.
And how that treatment program really works when people are living out on the
Yes,
street.
okay. So, okay, let me just start talking about that. Then there's a couple of slides to support it. So, what does the Project for Psychiatric Outreach to the Homeless do? Remember I told you that if you're going to treat mentally ill homeless people, you got to go to them. They're not coming to you. So what the Project for Psychiatric Outreach to the Homeless does, and other agencies like Project Renewal, like I imagine IFH also, right? Bowery Residence Committee, that's BRC. So there's like a dozen agencies in the city that do this kind of thing, is place psychiatrists in places where homeless people go sort of normally, right? So psychiatrists in shelters, psychiatrists in drop-in centers, not too many drop-in centers anymore, psychiatrists at soup kitchens, right? And certainly psychiatrists in permanent supportive housing, right? So even formerly homeless people who are now housed still don't go to the community mental health service, system, right? So what we do is we hire psychiatrists who are interested in this work, and we place them at these other agencies or these other programs, right? Now, the Park Avenue Women's Shelter, where we actually don't have a psychiatrist anymore, doesn't need a psychiatrist 5 days a week. They need a psychiatrist like 2 days a week, right? So before agencies like PPOH, if you wanted to do this kind of work, you'd work for like the Lenox Hill Neighborhood House 2 days a week, which runs the Park Avenue Women's Shelter. Then you'd work for the Neighborhood Coalition for Shelter 1 day a week because they used to run a drop-in center on 77th Street. You would cobble together this like schedule for yourself, and then maybe somebody pays your benefits, like that sort of thing. So PPOH, one of the sort of roles that PPOH has sort of grown into over the years to provide is like a one-stop for agencies to find psychiatrists and for psychiatrists to find like a salaried position, right? So that's sort of the structure of that. Now, what does the psychiatrist do at these places? So it depends on the kind of place you're at. If I work for a street outreach team or at a shelter, my main job is to actually provide a psychiatric evaluation for a housing application, right? So this so-called New York housing, right? New York refers to this agreement between the state and the city to provide resources mainly for housing for seriously ill homeless people, okay? We're on the third agreement now, and the fourth one just got announced that that's gonna happen, right? And so it sets aside money for a number of units of supportive housing that's attached to social service supports and clinical supports, right? So in order to be eligible for this housing, you have to have a serious mental illness. Well, who determines if someone's seriously mentally ill? The psychiatrist on the street outreach team determines that, right? Well, I say it in my evaluation, and then the Human Resource Administration is the city agency that decides if they agree with me or not, and they don't always agree with me, right? So that's the first main thing I do for someone who's literally homeless, right? Which is provide this evaluation that's required for their housing application. And the second thing I provide is care. Now, not too many street homeless people are willing to take risperidone like as they're sleeping on a park bench for good reason. Like, I don't want to be impaired by my medication when I have to fend for myself sleeping on a park bench. So there's not a lot of medication taking by street homeless people, but there's some. when I was doing street outreach, I used to carry around bottles of Cymbalta with me because Cymbalta was brand new and the rep was giving me free bottles of it all the time. And I actually gave out a couple of bottles of this stuff. Cymbalta is an antidepressant. And actually, I gave one to this guy who was living in this park up by 128th Street by the river. I forget the name of the park. And he actually 3 months later walked into my office on 121st Street, like looking like a different person, saying, you know, hey doc, that Cymbalta was actually the thing that helped me get it together so that I could work with the outreach team. He was like too depressed to even sort of participate in the process of getting housed, right? So like, you know, that's an N of one, but that's the story I like to tell about that. So that's, so street outreach and shelters is mostly that kind of work. It's evaluation for housing. Then in permanent supportive housing, so what's permanent supportive housing? That's housing for people who used to be homeless, and it's permanent. Like you can live there forever, theoretically. So if I am working at a place like that, and that's actually the one place I'm still working at, that is like ongoing care. It's basically I'm running a little outpatient clinic out of the basement of the old Christopher, it's the old McBurney Y actually, it's the old Christopher Hotel. So I have some number of patients I've been seeing there, some of them for about 10 years now, because I've been there for that long. And again, these are people who really weren't making it in the community mental health system, and I've got a couple of people who are, you know, chronically psychotic who refuse to take medicine, right? So those people don't make it in the community mental health system either because they're discharged if they don't take their medicine. And they're working with me, but they're coming to see me regularly and actually doing pretty good. Paying their rent, not getting into trouble, expressing gratitude for their services and their homes, and looking actually less psychotic, despite the fact that they're not taking medicine. And that's a whole other talk. So I hope that like sort of addresses that. Was there a specific question you had about that?
Well,
Yeah.
Well, I mean, you know, we think about, we talk about all of these folks being mentally ill.
Yes.
And you sort of wonder, like, okay, so what are you doing? So obviously you're not giving them medication.
Not everyone, right.
Very few.
Oh, yeah, so, okay, so.
You're basically doing evaluations to get them housed.
Right, and providing, right. Okay, so what's this care I'm talking about? So like, I just told you that a lot of people who I treat don't take medicine, although a lot of people, I do write a lot of prescriptions. So I've been painting this as like an access issue, right? Which it is. It certainly is an access issue that like people don't make use of the system that's out there for them. So we create another system for them that they actually come to, right? But actually, even that's not enough. So just sitting in an office in the building where a person lives is actually still not enough to get the person to come to you and to actually benefit from the service. What you end up also realizing is that, so let's say I do that, but then I just still like, okay, your appointment's at 9, your appointment's at 9:30. If you miss 3 appointments, I'm going to discharge you. Like that, even that doesn't work, even though it's just an elevator ride, right? So it requires things like if somebody hasn't made their appointment, I call them and say, I know you're in your apartment, like 4 floors up from me, get your butt on the elevator and come down here. And if the person hangs up on me, I march up to his apartment and knock on his door. It's like that kind of flexibility. Also, the person's not making their 9 a.m. appointment, but they sort of float in at 2 p.m. so that I make a space to see that person then. Also, some people can tolerate a 4-minute appointment. Some people really need 45 minutes, right? And then also certainly initial evaluations for a person who uses cocaine, uses heroin, has schizophrenia, has metabolic syndrome, has COPD. You can't do that evaluation in 20 minutes. That's like an hour or more to do that evaluation. Certainly the primary care people are finding that, who are doing this. So it requires like a level of structure, almost a level of no structure to like really, so it's not just access, it's also how do you do this differently than you do it in a clinic to make it effective? So, right? And then, so going back even to street outreach, like that's certainly, you can't structure that in any kind of way, right? So that's a lot of, I'll just give you an example of the kinds of things I would do. I would carry around this bag of coffee, right? And I would see one of my people, I'd say, will you talk to me for 10 minutes for this cup of coffee? Like bribing people. I never actually bribed people with cigarettes, but I believe me, I wasn't above it, right? If I sit with you in Dunkin', like today, what I would do is like, listen, there's a Dunkin' Donuts right there. I'll buy you a donut and coffee. Let's sit there for 20 minutes if you'll talk to me, like that sort of thing, right? So doing evaluations outside, bribing people with coffee, I'll tell you 2 stories, and then I'll get to more pictures. The outreach team once asked me, there's this guy who we're not even sure he speaks English, who hangs out under the Manhattan Bridge, like usually around East Broadway. Will you go find that guy and do an evaluation? I'm like, yeah, like definitely, right? Because what's more fun than that to be like do an evaluation in Chinatown, right? So I go to the Manhattan Bridge, right at East Broadway, and sure enough, there he is, right? He's got this big cart of garbage, right? And he's like, typical homeless person, like garb, right? 3 jackets. It wasn't that hot. It wasn't that cold. So I walk up to him, I introduce myself, and he just tells me in Fukienese or whatever language he's speaking to F off, right? So I walk across the street, I sit on a bench, and I just start watching this guy. And I write my evaluation watching this guy. And I say on my evaluation, because the Human Resource Administration is like, what the F is this, right? So I said, this guy wouldn't talk to me, but I observed him for half an hour. This is what I think is going on. And I say, this guy's obviously schizophrenic, right? And I have this history from the team. So it's like that, I wasn't taught to do an evaluation like that. Oh, here's another thing I would do is, if you start doing serial 7s, like, who's the president and what day is it, and like, do you count backwards by 7 from 100, like, you can't do that in Central Park, right? If a homeless person can tell you the score of the Yankee game last night, that's your cognitive exam. Like, and if you do like a MoCA or mini mental and this person scores 24 out of 30, what am I going to do about that anyway? Like, I'm not doing a CT scan in the park, right? So it's like adjusting your practice for like the reality of your situation. And also remembering that if I'm living on a park bench, like psychiatry is like the least of my concerns. Honestly, medical care is the least of my concerns. My top 3 concerns are, where am I going to get crack? Where am I going to get crack? Where am I going to get crack? And then, do I have some place to sleep tonight safe? That's number 4, right? Right? Then number 5 is, where am I going to get food? Right? So psychiatry is probably like 15. Medical care is maybe number 10. Right? So you have to like convince people you got something for them. And psychiatry is not it. Does that make sense? So, people who hear this, they're either like, oh my God, I could never do that. That's crazy. Or they hear that and they're like, oh, that sounds so much fun. And that's me. Like, it sounds like so much fun. So let me show you some more photographs and I'll stop. Okay, so here's the Park Avenue Armory. Park Avenue at 68th Street. Did you know that there's a women's shelter in this building? Every armory in the city has a shelter in it. Some of them are secret because they're domestic violence shelters. This is a permanent supportive housing. It's the Muhlenberg Residence. This is on Atlantic Avenue in fancy Boerum Hill, Brooklyn. I used to live in a building right behind this building. And when the psychiatry position there opened up, I took it. And what ended up happening, because I knew this was going to happen, I would end up walking my dog in my T-shirt and shorts and with my kids, running into my patients, and I wanted to see what that would be like. And it was awesome. Because my patients got this thing like, oh, that Dr. Yu, he's like a neighborhood guy, and he's a regular guy, and he's a nice dog. You can go see him, right? So people would tell their friends, yeah, you can see Dr. Yu. He's nice. He won't make you do stuff you don't want to do, like that sort of thing. So it was great for my engaging in that community that I lived in the neighborhood. I don't work there anymore, but that was fun. This is to remind me that there's a lot of outdoor office space at my work. Here's the lobby of the Times Square Hotel. Back in the day, this was like one of the fanciest hotels in the city, and then it became a heroin den. And then in '95, this agency called Common Ground, which does a lot of this, bought the building, gut renovated the whole thing, and turned it into the first and biggest, still the biggest, permanent supported housing site in the country. 650 people live here. You guys had a clinic there, yes, for some time. That fell apart for whatever, who knows, who remembers why. And actually, that door on the mezzanine is the door to that clinic, which we've got renovated. And for the last 2 years, we've been operating a clinic there ourselves. And now we're like, how do we keep financing it? Here is the roof deck of the Christopher. This is the old McBurney Y. So this is also permanent supportive housing. These buildings, by the way, are not all mentally ill people. It's usually divided into 3 populations. 1, seriously mentally ill. Number 2, HASA, HIV/AIDS services. Number 3, low income, people who have no mental illness, no medical illness necessarily. Some do, of course. So these are all mixed buildings, right? At some point, we can talk about the theory of supportive housing and why we do that. But anyway, here's the roof deck of the Christopher. This is where I see patients. I don't see patients on the roof deck. I have lunch on the roof deck, but I see patients in the basement. Here is the Skemmerhorn residence. This is on Skemmerhorn Street and Smith Street. This is fancy downtown Brooklyn. We built this building. And you can't see it, but so that's the back of the Skemmerhorn. And right behind this building are these $3 million townhouses. It's really funny. So all these people who live in these buildings, I think there's like 150 people living in this building. They're looking into the living rooms of these like rich and famous people. It's very funny, I think. And here's one of the apartments. It's nice. You know, when I was, 20 and single, I would have loved one of these apartments. And a lot of people in these apartments are exactly that. These young, in the low-income apartments, is these young, starving artists, a lot of these people. This is actually, we partner with an agency called the Actors Fund. So this building is all starving artists in the low-income units. Actually, 2 of my patients are starving artists who I'm doing weekly psychotherapy with. It's actually kind of fun. And this is the ballroom at the Prince George Hotel, which is also now permanent supportive housing, but used to be a fancy hotel. And you can rent out this ballroom, by the way, for your next event. And this is one of my favorite rooms in the agency. Here's the tea room at the Prince George Hotel, which you could also rent out for your event. Okay, so I'm not going to do any more slides. Any questions, comments, complaints? Yes, you first.
You want to give me a microphone?
Oh, okay.
So the people in Kingston can hear.
Right, okay, right.
Can't yell that back. Okay, is this working? Right?
I could also repeat the question or paraphrase the question.
Hello? Yeah, this is working. All right, my name is Joe Lurio. I'm a family doctor, and I actually do some work with homeless patients that come to our clinic from some of the shelters. I'm gonna make a statement more than a question.
Okay.
If I challenge you, then you can respond.
Okay.
A lot of times when I have medical students or residents, and I ask them what the cause of homelessness is, a lot of people will say mental illness.
Okay.
And I challenge them on that because I think it's stigmatizing. I think, in my opinion, homelessness is caused by lack of homes.
Uh-huh.
And that when there's not adequate housing, the
Right.
people who are most vulnerable are the ones, you're playing musical chair with homes. And so the people who are most vulnerable are the ones that lose the game of musical chairs. And they wind up on the streets.
Yeah.
And of course, being homeless is a comorbidity, and certainly
Yes.
makes any mental illness or any other illness, I would posit, worse. But I think by saying that homelessness is caused by mental illness, it's not only stigmatizing, but it's blaming the victim. And so I would say that we should probably get away from using that term, even though they're associated. I would say more that homelessness causes mental illness than the other way around. So I'm going to turn the mic off and hear what your response is to that.
I wasn't expecting that question, but it's an excellent point and question. And I'll start by saying that the vast majority of seriously mentally ill people are not homeless, right? So the homeless mentally ill are a subset and a small, in gross numbers, it's a lot of people, but if you look at seriously mentally ill people as a population, homeless seriously mentally ill people is a small subset of that population. So yes, it's not that mental illness in and of itself leads to homelessness, because most mental ill people don't become homeless, right? But one thing you did say I absolutely agree with is that mental illness leaves you vulnerable in a lot of different kinds of ways. I would say it even this way. Think about what it takes for you to stay in your home, like pay all the bills, pay them on time, have enough money, know how much money to put in those bills, do your laundry, keep your place, don't hoard. Like there's like any number of things you need to do to keep yourself in your home. It's hard, it's complicated. Like every day I joke that my second job is at home because I do all this stuff to keep everyone clothed and fed and like the rent paid and all this stuff, right? So, and I'm like, I'm a capable person, and I find it challenging, right? So if you are impaired by any number of things, not just mental illness, I think there's all kinds of other things, then it's just that makes it just you less able to negotiate the housing in general, but also certainly housing in New York City, right? And then the other thing you said that I absolutely agree with you is that the problem is not enough housing, right? But it's not even just housing. It's true, there's simply just not enough beds, not enough units to house all of the seriously mentally homeless right now in New York City. The New York agreements are trying to address that, every couple of years there's a new agreement to build more units, right? But it's not just, if I just had keys in my pocket and start handing them out, even that wouldn't be enough, right? And even though that's basically the philosophy, that's the housing first philosophy, just hand people keys, right? You need to provide all kinds of support for people who are vulnerable for these variety of reasons, including mental health, right? So I'll just give you an example of how that plays out. So we have people at a place like the Christopher, 180 people living there, permanently supportive housing, a third of whom are formerly mentally ill. And there's a social service team, I'm there a day a week, there's a primary care team there a day a week, and still people get evicted, right? For, a variety of things, like drug trafficking in the building, getting into fights in the building because you're high all the time, and like high people get into fights more often than sober people, like this kind of thing. So even with all that support, people still can't stay in their housing. So it's the housing stock, it's the availability of housing, and also getting enough and the right kind of support into those places. And there's even a subset of those people we haven't quite figured out how to keep them in, right? So it's typically the substance user who, because of their substance use, engages in a lot of criminal activity. Like those are the people we're having a lot of trouble sort of keeping them in housing. So I don't know if that addressed your question adequately or appropriately, but that's what I have to say about that. Yes.
Hi, I'm Lily. I'm a medical student.
Uh-huh.
I guess you talked a little bit about chronic homelessness, and you talked about the one man who you gave antidepressants
Yeah.
to, and how that kind of spurred him to work with the street outreach team. I was
Yes.
wondering if you could address the role that psychiatrists play, or that you have played in kind of convincing people to seek out housing or services when a lot of people are resistant to even engaging in those systems.
Yeah, well, the key word is engagement, right? So the first job of the team, and the psychiatrist being included in the team, is to get the person engaged with you, get the person participating with you in whatever the process is, right? And that ends up being, for some people, very, very difficult, right? So, for example, people whose mental illness leads them to believe that the outreach team is like an evil agent of the government, for example. Like that's going to be trouble. That person's not going to you're not going to have an easy time convincing that person to work with you, right? So that's the first challenge. And the psychiatrist, you don't need the psychiatrist for every person to get them engaged. Often the team is actually much better than the psychiatrist at this. I'll give you one example of how this worked with somebody. Remember the dogs, the picture? We had a guy who believed that if he started working with the outreach team, he would lose the dog. Not an unwarranted belief, and not a belief coming out of psychosis. That was like a real legitimate concern that he had. Even though it's not true in that case, like why would he trust me to believe that, right? So one day, he was picked up by the cops on like a trespassing or public drunkenness or something, right? And spent however many hours he spent in the tombs for that. And a couple of people on the outreach team hung out with his dog and prevented animal control from taking the dog, right? And then shortly after that, he started working with us and is now permanently housed at the Prince George with his dog, right? And when somebody asked him, like a couple years after that, so why did you decide to start working with the outreach team? He said, well, they took care of my dog. After that, I felt like I had to work with them, right? Like it was like almost payment back to us for taking care of his dog, right? So that's you don't need the psychiatrist for that, but it's just an example of the team's got to be able to come up with that strategy. That one seemed obvious to me, there's the dog, you take care of the dog, right? But that's not like in a textbook somewhere, you know what I mean? It's like not in the procedure manual of our outreach teams. Does that make sense? There's a question over here. Yeah. And while the microphone's moving, so in some cases, though, the psychiatrist does have some insight into like what's the best way to approach a particular person who has a particular psychiatric symptom in a way that has the best chance of engaging the person, that's like least threatening, that's like that sort of thing, right? So that would be the role of the psychiatrist in that initial stage of things. Yeah.
So, I mean, you described a number of skills that are not many clinicians are trained in.
Yes.
So I'm just wondering if using our medical model really makes sense.
Uh-huh.
I mean, you describe things that anthropologists do and sociologists do, and that, you know, when we think about psychiatrists and we think about people who are trained in primary care, they're not trained to work in these settings.
Yes.
Have those skill sets. And it sounds like having somebody who could have multiple skill sets, who would be able to observe somebody and assess them from a distance, who would have some expertise around primary care, and be able to use motivational interviewing.
Yes, for example, yes.
So, like, it seems there's a disconnect between using a conventional healthcare model with a solution that really requires a different skill set.
Yeah, I 100% agree with that. Yeah.
So, what would that look like? If we were to do this right, what would that look like based on your experience?
Well, the first thing that comes to mind is like you'd have to finance it a completely different way, right? So a lot of the structure of medicine, I don't know that this is the reason it started this way, but a lot of the structure of medicine these days is driven by how it's paid for, right? I'll just give you the starkest example. Right? I need to see 25 people in a clinic to make my salary. Just something as simple as that, right? And so that means people have to come in time. You got to double book to make sure people show up, like this kind of thing, right? So that's not because the medical people want it to be that way. It's just that's the way it is, right? What I'm describing to you is like, I called it unstructured before. Like, the more I do this, the more unstructured my personal practice is with these people. Like, it's like, some days it's like a free-for-all in my office, right? It feels that way anyway. And so you have to, I think, just off the top of my head, you put people who have this kind of skill set, either learned or inborn or both, in a place where they have the freedom to be this flexible, to figure out for each person, it's like really person-centeredness, right? What is gonna work with this person? Is it gonna be one of the 10 things I've already tried, or is it gonna be a brand new thing I've never thought of, right? Is it gonna be in this person's apartment, in the lobby, in the Dunkin' Donuts across the street, right? Here's one thing, just another example. One of my nurse practitioners, like fresh out of school, realized this on her first day. Like, oh, I can't even talk about labs on my first day. I can't even take a blood pressure on the first day. The first visit is, hi, how you doing? My name's Emily. What's your name? Like, what's going on with you, right? Just to get the person like, oh, I can go see that. She's not going to stick a needle in me every time I walk in there, like that sort of thing, right? So you need that kind of very flexible structure to the extent that that's even structured. And then, because we're all us three are administrators at least, like, how do you finance something like that? That's what I haven't figured out, and that's what keeps me up at night, because there's no, even though the managed care organizations realize that's cost effective, they know it is. They're beyond wondering if that's cost effective. There's no infrastructure in place for them to finance it in a way that makes sense to them yet, in a way they want to, or are forced to at this point, right? Like, if they're not forced to do it, they're not, so one of you just said it, right? If they're not forced to do it, they're not going to do it. Why would they do it, right? So
anyway, there's two things that you said that I think are absolutely on target. So first of all, you used the term person-centeredness.
Yeah.
We're all talking about that. I think you described today a model of that that we could all emulate, which is really, taking care of the dog if that's what needs to be taken care of. Because our systems are built so far away from the ability to do that. The second thing is there's a little bit of hopefulness, I think, if people are really talking about financing systems based on outcomes, and we really get to that,
Yes.
and really get to value-based payment, and we really can say, we're going to give you a certain amount of money to take care of people for a year,
Yes.
and incentivize you to keep them out of the hospital and out of the emergency room, then all of those things that you're learning are going to come to play, and those are going to become the important things for all of us to do.
Yeah, I agree with you. I'm hopeful for that kind of payment
So
system.
hopefully we'll see that transition. And I want to thank you because I think this was really eye-opening and really encouraging in so many ways. Thanks a lot.
Thanks. Well, thanks for having me. I really enjoyed it. Thanks.